I'm excited to introduce our next speaker, Kevin McCullough. He's our HIV pharmacist with Walgreens Specialty, and he's going to be talking about polypharmacy and aging in the HIV population. And one side note, I've known Kevin for a long time, and he was my softball coach.
You played softball.
Nope, he tried, but guess what? Never could make it happen. So thank you, Kevin, for joining us.
Hello, everyone. So tonight we're going to be talking, or today, I'm sorry, we're going to be talking about polypharmacy and aging in the HIV population. So financial disclosures, I have none. So my learning objectives: understanding the unique challenges in managing HIV in the aging population, HIV and drug-drug interactions in the aging population, polypharmacy and how it relates to HIV in the aging population. And we're going to touch a little bit about immunizations in the aging population. So this talk pretty much is about how our population is aging in the community and how different things can be associated with those patients as they age. So what's a pharmacist's role in an HIV setting? So I've been a pharmacist for, as Jeff said, 41, going on 42 years. I grew up in the Midwest. When HIV became I became a pharmacist in 1983, and HIV was just coming around. As the late 80s came in, I met a few patients that were HIV positive, and it intrigued me to get involved in that. I moved here to the desert a little over 20 years ago and really got involved with HIV treatment, got involved with my patients, and it really inspired me to be that pharmacist that could be there for those patients. But pharmacists, there's a misconception of what a pharmacist does or who a pharmacist is. And there are many different avenues pharmacists can go down to. As me, I'm a pharmacist that works in somewhat of a specialty retail site. Most people think of pharmacists are behind the counter, counting and pouring and dispensing your medication. But really, pharmacists are much more than that in an HIV setting. We do manage medication and we do dispense them. We're there for adherence support. We monitor and manage the drug side effects, often for patients. We're there for prevention and education. We collaborate with different healthcare providers and healthcare teams during a daily basis. Long-acting HIV treatments. Pharmacists are becoming more involved with long-acting HIV treatment, and hopefully as time goes on with the new HIV treatments that are coming down the road for injectables, more pharmacists will be hopefully administering those kinds of drugs. And we're also involved in patient advocacy and support, monitoring for co-infection and comorbidities. Immunizations it's been talked about already today, but preventative care is very important with our HIV community and especially aging. So getting those immunizations done on a yearly basis, if it's once a year, like a flu shot, or doing your COVID shot for the immunocompromised patients are very important. So we'll talk a little bit about that. And also, pharmacists are very easy to go in and see on a daily basis. You can pick up the phone and call and ask to speak to a pharmacist pretty often. You don't even have to be a patient at a retail site or an HIV setting to speak to a patient, or I'm sorry, to speak to a pharmacist. So sometimes it's easier just to walk into a pharmacy and ask those questions, where if you need to go to a provider, you have to wait for your appointment. So they're easy to access often. And also patient education and counseling. So managing HIV in the aging adult. So HIV is considered a chronic manageable condition. Most patients can be controlled on a 1-tablet daily regimen, which is unbelievable nowadays. I think it was brought up earlier today when the triplet came out. That was just like the thing that everybody wanted to be on. And nowadays we have many more prescription drugs that is just a 1 tablet a day for the most common person. Advancement in antiretroviral therapy has improved life expectancy. More and more patients are living longer. More and more patients have the capabilities of living a life which is comparable to a non-HIV patient now. So it's becoming much easier to take a tablet every day and live a normal life. And HIV population is increasing due to effective treatment. So we're getting more and more patients that are being virally suppressed, and this is more beneficial for the patient. And they're developing, or as becoming virally depressed, these patients are living longer. And by living longer, we're going to see more and more health conditions that possibly will be affecting these patients going down the road. So HIV and aging demographics. So according to the CDC in 2022, of the nearly 1.1 million people living with HIV in the United States, approximately 54% were age 50 and above. Also, people living with HIV are age 50 and older accounted for 16% of the newly HIV diagnoses in the United States. So what this means is that the more people we have in those age groups, the more issues they may be having going down the road with comorbidities. So it's going to be a very interesting road we go down as time goes on to see how different health conditions are going to be affecting patients and what medication they're going to be put on to treat those health conditions, and have it compared to what HIV treatments are already on and what we're going to have to do to actually manage those patients. So there's an increase in prevalence of comorbidities, as I said, when we get older. So we have cardiovascular issues, hypertension, renal issues, bone mass density, diabetes, and mental health. All of these things could add a number of prescription drugs that a patient may be on. So these different medications could pose issues with HIV treatment and what patients are already being treated with. So we may have to reevaluate what patients are taking and decide what might be better for HIV treatment, or maybe go down the road with another drug or drug class to actually treat those other health conditions that are experienced. So what are some more challenges in HIV and aging? So we have an increased risk of drug-drug interactions and adverse events. HIV-related inflammation may contribute to early onset of age-related frailty and cognitive impairment. As patients are getting older, we're going to have a need for geriatric HIV care due to aging population. And even in the non-HIV community, as patients get older, the increase in frailty and cognitive decline is there. So we're going to also see that with our HIV community too, because like I said, our HIV community, they're going to be living normal lives, and their length of time that they're going to be on this earth could develop into a problem to where they're having frailty and cognitive decline problems. So as healthcare providers, aging and comorbidities do pose a therapeutic challenge. Age-associated changes in pharmacodynamics. So changes in the affinity of some medications to receptor sites or the number of receptors may affect efficacy or increase the sensitivity of certain drugs. Also, regulation of physiological processes like hepatic and kidneys may alter due to aging. So in this respect, as patients get older, the way they metabolize drugs and the way that they excrete them is going to be different than when they were 30 or 40 years of age. So we have to be cognizant about what happens to that patient as they do get older, and how are we going to change the makeup of what their prescription profile may be. And in this, we can talk about a few different classes of what happens to an aging person when they're taking certain classes of medication. So pharmacodynamic effect from taking an antihypertensive drug, you may have orthostatic hypotension. And in those kind of patients, you may want to start at a lower dose and then increase it as needed. Same thing with benzodiazepines. The aging population are more sensitive to benzodiazepines. So you don't need a normal or regular dose for those patients. You may want to start as low as possible, use that drug as needed, and try to wean those patients off when they don't actually need the drug. Opioid sensitivity is increased as we get older. And we see this often with possibly patients treating for neuropathy pain while they're as they're getting older. We're often putting patients on opioids, but you want to start at a low dose. Also, people that may be going into surgery for hip replacement or what have you, they're going to be discharged with possible pain medication like opioids. So you definitely want to start those patients at a lower dose and increase them if needed, and always make sure that when the patient is done with using pain medicine, you want to have them taper that off and don't want them to continue on with something that they really don't need. Beta blockers, aging population, their beta receptors are less responsive. So using beta blockers, you may have to use an increased dose for those patients to get that effect that what beta blockers are used for. Diuretics, Asian populations are more sensitive to these drugs. So you want to monitor those patients and check in and make sure that their labs are good. And when you're using a diuretic, you want to make sure that if you're using a diuretic that depletes potassium out of the body, that you replace that potassium for those patients. And anticholinergic agents. So there are a lot of drug classes that actually have side effects of anticholinergic. We have the antiemetics, you have drugs that treat Parkinson's disease, you have bronchodilators, you have tricyclic antidepressants that actually can cause problems in the aging community. So one perfect example is an OTC drug like diphenhydramine or Benadryl. Most people aren't aware, you go in a drugstore and you can pick up Benadryl. You can use it for allergies, cold symptoms, but it's also in a sleep aid, Nital. And the aging population, when they have a problem sleeping, they often will go get those products. Well, they may develop other issues when they take these drugs, and they actually cause anticholinergic side effects. And those side effects could be agitation, confusion, decompensation of glaucoma, dry mouth, constipation, and urinary retention. So you often want to avoid drugs like that in the aging community because it's harder for them to actually metabolize or deal with those medications. So antiretroviral therapy in the aging adult, what do we need to look at when our clientele or our patients are getting older? You look at pharmacokinetic changes. You also need to look at age affects drug metabolism and clearance. You possibly need to adjust the dosing that may be needed to treat HIV. And drug-drug interactions are totally a must to look at because you never know when you put two drugs together what's going to happen. So we also want to talk about polypharmacy. So polypharmacy is a simultaneous use of medication by a patient, often defined as 5 or more drugs. Now, when you think about 5 or more drugs, well, what about an HIV patient? 10, 20 years ago, we had HIV patients that were taking 10 and 15 different drugs because they had to take multiple drugs in order to treat their HIV, but they were also taking drugs from the side effects of the HIV drugs they were taking. But now we're taking 1 tablet a day. We can almost say that polypharmacy is 5 drugs for an HIV patient. It could be a normal situation going on. So with polypharmacy, you have an increased risk of drug interactions. There's a higher potential for adverse drug reactions. The potential for reduced adherence to HIV could be possible because patients, when they have adverse drug reaction or they have interactions, they may stop taking certain medication that they think that's causing the problem. And pretty often it's their HIV medication. And when you stop taking your HIV medication, of course, your viral load is not going to be suppressed and the HIV virus is going to come out. And then then all of a sudden you have the infection back there. The patient comes in the doctor's office, does some labs, and where the viral load is, it's all up there. And so, and nobody knows why. And then the patient finally says, oh, wait a minute, I don't take my tablets every day, or I only take it when I feel good. So we hear this often, and this is an example of what happens when you have adverse events or side effects from medication. So some questions you need to ask when there is a drug interaction. You want to ask what the what the interaction is. You want to ask what the mechanism is. And you want to ask to yourself, what should be the recommendation for these patients? Do I need to stop certain medications? Do I need to tell a patient to take it at a different time of the day and not take it with another medication? Does the patient need to take it with food? There's so many different situations that can happen, and you want to make sure that you're treating all the health conditions that the patient is actually experiencing. So here's some types of drug interactions. We have pharmacokinetics and we have pharmacodynamics. So pharmacokinetic interactions are your absorption, your distribution, your metabolism, and your excretion, or your elimination of the drug. In the pharmacodynamic interactions, you have additive, which is like 1+1. You have the synergistic, which is the whole is equal to greater than the sum of its parts. And you have the antagonistic, which drug interactions of two or more drugs that kind of fight against each other in the body. So I'm not going to touch much on this slide here because we can get really into different potential interactions of ARVs, whether they're inhibiting certain drugs or they're inducing other drugs. But what I wanted to share is that different drugs can be affected or affect other drugs depending on where the drug is in the body, whether it's absorption, metabolism, or excretion. And a perfect example is having a certain pH in your stomach for certain drugs like protease inhibitors and ripivirine. If you don't have food on your belly for those drugs, your pH is not high enough, and those drugs are not absorbed to the point that they need to be absorbed. So you could actually lose the effect of those drugs if you continuously don't take those drugs with food. Same things with chelation. So taking over-the-counter items like calcium, magnesium, iron supplements, these drugs can affect integrase inhibitors. So taking those drugs with integrase inhibitors could totally disallow those drugs to be absorbed. So you want to usually separate those drugs over the counter, like the iron supplements, calcium supplements, 2 to 4 hours before or 4 to 6 hours later, so that those integrase inhibitors can actually get absorbed and work. So metabolism of ARVs. So these are the 5 major categories of most antiretrovirals. We have the NRTIs, which is like the emtricitabine, the lamivudine, tenofovir. Most of these drugs are secreted or excreted by the kidneys and do not participate in interactions in the liver. And we also have the entry inhibitors like maraviroc and fostemsavir, which is Rukobia. We also have the NRTIs, protease inhibitors, and the integrase inhibitors. These drugs are all metabolized in the liver and can be affected or can affect other drugs that will be taken along with them. So whether or not, the HIV drugs are the victim or the drugs that they take with them are the victims, it's hard to say, but you need to determine what each drugs do in the body and how other drugs may affect them. So here's a list of some of the strong potent CYP3A inhibitors. And we're just going to, this is just a small list. There's a huge list out there on how drugs can affect other drugs. The drugs on the left side can actually increase the area under the curve of substrates tenfold, more than tenfold. And you see this with the boosters like povecostat, and you see it with ritonavir. Those definitely can actually inhibit drugs to where they're increased in the body. But there are other things like the antifungals, like itraconazole, ketoconazole, voriconazole. These drugs are also major inhibitors of drugs that actually can increase levels of the body. And also we see other drugs like clarithromycin, dotaxin. We don't think about some of these drugs, but they also can inhibit and increase drugs in the body. And hopefully your pharmacists will actually be catching those. So the next couple of slides, there's a lot of information on these, but I'm just going to touch a little bit about how these different things and the interactions of the drugs can actually be affected. So using the proton pump inhibitors, using antacid and H2 blockers, along with ripivirine and atazanavir, these drugs are either contraindicated or they're indicated to be used at different times during the day to actually get the proper absorption of the drug. Ripivirine, like we mentioned before, requires like 300 calories in order for the pH to actually be increased. Atazanavir needs food on the belly to actually work and get absorbed properly too. calcium calcium minerals and mineral supplements, vitamins and acids. These all can affect the integrase inhibitors. So integrase inhibitors will form a complex with divalent cations at the level of the GI, and they will prevent the absorption of those drugs. And a lot of patients will not even know that until they actually go in and get labs and find that their viral load has increased. So hopefully, you're getting those questions asked by the physician, by nurses, by pharmacists when patients are actually coming in and get their integrase inhibitors or their HIV drugs. Or if these patients are coming in and saying, hey, I take a multivitamin every day, or I'm taking calcium, hopefully somebody is actually talking to them saying, well, wait a minute, you're an integrase inhibitor. We need to actually educate you on when to take those when you're taking your ARVs. Also, we see fluticasone, which is a nasal spray, which is a corticosteroid over the counter. This drug can actually be a major problem if you're taking it on an ongoing basis. And it can cause Cushing syndrome when taken with protease inhibitors that are boosted. So you need to be careful with that. If you're going to be on a concurrent use of a fluticasone, you can always use an alternative product like beclomethasone. But you also need to make sure that you're also, if a patient is taking ongoing prednisone or even using a topical corticosteroid, eye drop or eye ointment, they could be even using a topical steroid. If it's being done on a regular basis, they can actually develop Cushing syndrome based on their own genetic makeup. So you don't know what levels of corticosteroids that need to be given or that can be given with a protease inhibitor. So you just need to make sure that you watch out for those signs of the Cushing syndrome. And as we talked before, antidepressants being taken with protease inhibitors, especially the tricyclics, can cause major problems of anticholinergic effect. Benzodiazepines, they're boosted when it comes to using it with a protease inhibitor that's boosted. So you need to avoid those with the elderly. In this screen also, it's pretty much all protease inhibitors, but be careful with using anticoagulants, vitamin K, calcium channel blockers for blood pressure. The peripheral alpha blockers like doxazosin and prazosin can majorly cause orthostatic hypotension. Statins, as has been talked about before, using them with protease inhibitors can cause major problems with the increase in muscle spasms. So patients coming in for complaining of muscle spasm, you can look at their profile and see what they're taking and actually determine that it's actually being caused by their medication and not by a health condition. And chemotherapy drugs, so when a patient is actually diagnosed and they need to be medicated with chemotherapy drugs, you want to make sure they're not taking a protease inhibitor that's boosted. And if those patients are being medicated with that, you want to make sure that you reevaluate their HIV treatment, at least during their chemotherapy treatment. And, and just watch out for signs of toxicity if they are on the protease inhibitor. And last thing is NSAIDs. Taking it with tenofovir. Tenofovir is excreted in the kidneys, and so you want to make sure that you're not using excessive amounts of NSAIDs like ibuprofen and naproxen over the counter. This could cause a problem if they're doing it for a regular basis. So drug-drug interactions and the scope of the problem. So we know drug interactions, you can't have a drug interaction with one drug. But as soon as you add a second drug, a third drug, a fourth, you start multiplying how many drug interactions you could actually have. But not all patients that receive interaction drug experience a clinical significant drug interaction. And those are based on like genetic signs, disease states, and other contributing factors. All right, adverse drug reactions in the prescribing cascade. So you have a drug and you prescribe a drug. The adverse drug effects is misinterpreted by a physician or by a healthcare provider. You add another drug to treat that adverse event. The patient comes in and still is experiencing something, you add another drug. This could continue until you actually look at a drug profile of the patient and find out, hey, what's going on? Are we giving medication that's actually causing the problem? Or are these medications being used to treat an actual health condition? And by increasing the amount of prescription drugs that somebody is given, you're more likely to get more adverse events. A patient it's going to be experiencing more issues with side effects. They're more likely to possibly quit taking certain medication, and more than likely, they're less likely to continue their HIV drugs because they think that it's more HIV drugs that it's actually causing a problem. And then all of a sudden, now their virus goes up, and you possibly could lose the actual treatment. Excuse me. So here's some neurotherapeutic index drugs, which could possibly be victims for ARVs. So a small difference in dose or blood concentration of these compounds may lead to therapeutic failure or ADRs. So a few on this list, we can talk about warfarin, levothyroxine, carbamazepine, lithium, digoxin, phenytoin, theophylline, sirolimus, tacrolimus, which are used for transplants, quinidine, amiodarone, flecainide. These are major drugs that have a small therapeutic index, and by taking them with other drugs that could boost them or decrease their effect, could actually be harmful to the body. Same thing goes with drugs like Eliquis, Pradaxa. These things are drugs that have a very small therapeutic index and are used all the time. And we always need to look at patients and reevaluate which drugs you can use and or possibly change their ARVs. So managing drug interactions in the aging population, things to think about. Consideration of ART, regular medication review to assess the risk of DDIs, dose adjustments based on their renal and hepatic function, prioritize regimens with fewer interactions in patients with polypharmacy collaboration, and team-based care involving pharmacists, HIV specialists, and geriatricians. So here's some tools for managing DDIs. Clinical decision support systems, having a buddy system, having another physician that you can bounce ideas off of, having another pharmacist you can call and ask questions and see if they support your decision-making, have a nurse that, can come to you and actually discuss what's going on. You need to have that buddy system because you can't know everything. And yes, we have Google and we have other things that are at our fingertips, but it's really good to have another clinician or person that you can actually bounce off ideas. Alerts and electronic health records of potential DDIs, drug interaction checkers, online database. I use Liverpool HIV drug interactions all the time. It's an app you can download to your smartphone. It's a great app. It updates all the time and it really gives great information. But I suggest doing that to your on your smartphone. And we also have Lexicon. And also there's regular monitoring of blood pressure, labs of organ function, and just basically the overall feeling of the patient. How's the patient feeling when they come into you? Are they better than they were before they were coming in and were complaining about other health conditions when they came in? So now we're going to talk about a little bit about vaccinations. And I know this is what we talked on before, but preventative care is the ultimate thing that we need to look at when we're talking about our aging population. Getting a flu shot every year, COVID for the immunocompromised patients, suggested by the CDC to have every 4 to 6 months, especially when there's a new strain that comes out and they're going to update the COVID vaccination. Influenza B, hepatitis A and B, Mpox is really important to get those first 2 doses in. Prevnar, the pneumococcal, is really important, and I think they just lowered the age on that for the non-HIV down to 50. But it's really important that your patients who are HIV positive that are on medication they need to have that pneumonia shot because pneumonia is one of the #1 reasons why a patient ends up in the hospital. So getting that vaccination will help prevent that. The shingle shot is a 2-shot series. Patients over 50 can just walk in the pharmacy and get those. And also the RSV that just came out a little over a year ago is really important for the patients to actually have that protection. So in conclusion, aging HIV population is growing, leading to more complex treatment decisions with persons living with HIV. Polypharmacy increases the risk of DDIs and needs to be evaluated. A thorough medication reconciliation includes assessment of OTCs and dietary herbal supplements is warranted. Reputable resources are available for accurate screening and management of potential DDIs. And always review with your patient their list of vaccinations and what they've completed and what they need to get done. Thank you.